السلام عليكم ورحمة الله.
Waalaikum salam.
Can you hear me?
Yes.
Very good morning for all of you. How many candidates now available? 25 only?
26.
It is counting me now. How many original candidates? The number? How many?
26, Doctor.
26. So there is one remaining?
Yes.
Okay, we'll give him 5 minutes. After that, we will claim he is absent. Okay. Someone can call him that we are going to start, please. Let us start by Al-Kitab. Can you see my screen or not?
No.
Okay, share screen now. Now, can you?
Yes, Doctor.
Good. Is it okay now?
Yes.
Okay. So let us start by Bismillah ar-Rahman ar-Rahim. It is very important you are now in your 5. So it is just a few months. You will be eligible if you are talent for practicing medicine. Practicing of medicine is an important responsibility, okay? Because you are assigned by the Ministry of Health and even by religious background, you are not allowed to cause harm. You only allowed to give benefits, okay? Sometimes it is unavoidable, but even we must try to predict and decrease it to the lowest or try to avoid it. Today we are speaking about the birth trauma. As you know, birth, we cannot ask every woman to deliver by cesarean section. It is not wise at all. And even cesarean section is not free of other complications. That's why we are going now to speak about the injuries which can come to the baby during the birth process and how can we avoid it. This is our outlines today, either injury to the head or nerves or skeletal and muscle injuries or even some congenital injuries. So sometimes this injury can occur either due to compression or traction during the birth process. Okay, like compression, if the pelvis of the mother is slightly narrow, the baby will put compression for his head. He can put big Cephalohematoma or Caput Succedaneum. Traction, if the baby already have like shoulder dystocia or like that, and we are trying to release him. Okay, All these are known as birth trauma. You see, even we are there, the incidence can come to 7 per 1,000. And this 7 per 1,000 can cause about 2% of the neonatal deaths. This is an important issue. Is there any factors can be predisposed to the injury, so we try to avoid or not? If you cannot hear me, please inform me. Is it okay?
Yes.
Okay,
Okay.
Doctor.
So slides in front of you. Who can tell me the factors now? Just read it for us.
There is a prolonged or rapid delivery, deep
Okay.
transverse arrest of presenting part of the fetus, oligohydramnios, breach, and dystocia.
Okay, so if we are trying to comment about that, rapid delivery means as precipitate labor. It means the uterus are contracting very, very vigorous and trying to push the baby out even within few minutes. Of course, it can cause trauma. So if you found any mother with prolonged, it means the second stage, as you will got in ONG, is prolonged than the normal, which is 2 hours or like that. Or if the delivery is so rapid, both of them can cause harm to the baby. Okay? If the baby is transverse arrest, he is arrested transversely, and at the time the ONG preparing for the cesarean, they are trying to make handling of the baby. Okay, oligohydramnios is very important because this labor, Allah make the function of the amniotic fluid to lubricate this delivery until the last minute. So if it is dry, sometimes it will be make difficult. Abnormal presentation, breech presentation is very, very, very dangerous to try to deliver the baby with breech. Why? Already the leg will pass and then the trunk will pass, but maybe the head is hanging and you are in trouble at the time. That's why most of the breech, the original thing is to go for cesarean section, because at the time, if trying to push the baby down, you are trying to make traction over the baby, you may cut the nerves of the cervical plexus, which can end by death or deformity. Okay, of course, dystocia also, it is the same. The shoulder came out and hanged already. So all this, if you are going to go ONG, you must take care. If you are working as a neonate, you must take care, okay? Because many of this can be presented by fetal distress or respiratory distress or baby birth asphyxia, okay? Also, use of forceps and vacuum extraction, which means as an instrumental delivery, we are trying to decrease the use of it as we can, but sometimes the baby came fully or crowned. And the doctor to do also cesarean section, it will take some time. So they are trying at this limited time just to use mechanical delivery, okay, for extracting the baby. It can cause some harm. Very low birth weight infant and extreme low birth weight also can be affected by delivery. Macrosomic baby, more than 4,000 grams. Macrosomia means more than 4 kilos. Okay, it can cause a lot of trauma to the baby and to the mother. Okay, and also there is disproportion between the pelvic and the baby. Okay, it is can be affected. The baby has fetal anomaly like macrocephaly, and no one diagnosed him before, like that. That is the issue. All of this can precipitate to birth injury. So how can we classify now? Let us classify either into soft tissue or in the skull. Soft tissue can be just a simple abrasion. And it happens many times while the staff are opening the uterus. Sometimes the blade can touch the scalp and you will find a simple scratch or wound in the scalp. Usually the healing are very rapid and no effect, and just take care about that, okay? Erythema, BTK, why baby can get petechial rash in spite of petechial rash are very dangerous in any patient. If you found any BTK, it's very dangerous. But in baby, because of what I can say, after stress, after compression of the baby during the passage in the birth canal, he will come to the dunya very wide. So it can rupture of the vessel and decay and cause this BTK. So it is not usually very dangerous like after that, unless there is another clue in our food blood count or coagulation profile, okay? Of course, ecchymosis, laceration, subcutaneous fat necrosis can occur sometime due to compression. For the skull, we can find a lot of things who can read this abnormality or birth injuries to the skull. Who can read the birth trauma to the skull?
Birth trauma to the skull, there is a Caput, Succedaneum, Cephalohematoma, subgaleal hemorrhage, linear fracture, and intracranial hemorrhage.
Let us ask ourselves, what is Caput Succedaneum? Anyone knows? This is a lesion occur due to the skull itself, which is the caput. Succedaneum mean like accident to the bone of the pelvis or the maternal passages. Okay, we'll saw it. Cephalohematoma means hematoma in the bone of the skull. Subgaleal hemorrhage are very, very dangerous. It means hemorrhage in the subaponeurotic hemorrhage. This is an aponeurosis starting from the eye until the posteriorly to the neck. If hemorrhage occur in this subgaleal hemorrhage, okay, it can accommodate 50% of the fetal blood. So the baby can get shock easily if you didn't diagnose and follow up the baby. Of course, linear fracture, intracranial hemorrhage can occur, but usually less in incidence unless severe prematurity. For the face, it is very important, subconjunctival hemorrhage. It is the same because of compression, then release. Retinal hemorrhage also, okay, can occur, but they are not so dangerous. Peripheral nerves can be injured, like the brachial plexus, the vocal cord paralysis, sometimes radial nerve or lumbosacral injuries, okay? Cranial nerves and spinal cord injury, which is the one of very, very dangerous. Facial palsy, how can we diagnose the facial palsy? Seventh cranial nerve. You will ask, or someone will answer. How can we diagnose the seventh cranial nerve palsy?
When there is asymmetrical in the face of the fetal baby.
Okay, good. Who else can add? Now we will find asymmetry. I need someone to say what this is asymmetry.
Loss of nasolabial fold.
Excellent.
Drooping of mouth edge.
So what will happen to the angle of the mouse?
Unable to close properly, cause drooling.
It can occur, but mainly it will be the angle of the mouse will be shifted to the normal side. So it is asymmetry here by two things. The angle of the mouse will be shifted to the healthy side, and the nasolabial fold, it will be absent in the affected side. Then you will come to the eye to say it is lower or upper. So which is which? When we can say it is lower motor or upper motor? Okay, this is the,
when there is sparing of the forehead wrinkle.
if it's bearing, it will be
Sparing will be upper motor.
upper motor neuron. So remember that the lower motor neuron will affect both of them, which you can see a lot in pediatric population. If sparing, it will be lower motor, it will be in adults, and it can go with some accident, cerebrovascular accident. Okay. Sternocleidomastoid muscle can be affected also, or clavicle, both of them in the neck, and we'll speak about that. Okay, please don't forget to revise the cranial nerve presentation. Okay, you can do it on the group and send it to me, please. The presentation, only the symptoms and the sign of cranial nerve affection, because most of you are panic when we come to the cranial nerves. Then, which is very dangerous, the intra-abdominal hemorrhage, intra-abdominal injuries, like liver, spleen, adrenal, renal, all this, especially liver and spleen, before they are doing resuscitation by a very vigorous manner, they will catch the baby and try to slap him very strongly, to cry like that, or sometimes they are making him hit chest by very vigorous one. It can cause liver laceration or splenic laceration. It's a hematoma, can also cause internal hemorrhage, which can lead to death of the baby. Okay, that is the abrasion and the laceration. Okay, can be occur for many cases, but it needs only careful cleaning, application of antibiotic ointment, observation. Laceration occasionally requires suturing, even no issue. Sometimes you just need to make documentation for that. Okay. The healing issue for the neonate is very good. What is this? This is subcutaneous necrosis, can occur. So what is the subcutaneous necrosis? It is irregular, hard, non-beating. It is irregular. Number one, irregular. Number two, it will be calcified, so it will be hard. Non-beating, subcutaneous induration with overlying dusky red-purple discoloration of the extremities. Can occur in the extremities, face, trunk, buttock, may be caused by pressure. Okay, no treatment is necessary. Do we miss any? Okay.
Doctor.
Yes.
Sorry, the other student, she had problem with her internet since before 11, so she had problem entering the class. I would just like to inform you.
Oh, only one?
Yes, only one, doctor.
Okay, you need to forward him the lecture, and you will ask Sister Farah to offer him to see it after. Okay.
Okay, thank you, doctor.
But inform her that he cannot attend due to that issue, or he must be the.
Okay.
So now if we start by the skull, usually in unit we are working from head to toe. So this is Caput succedaneum. It is edema of the presenting parts due to pressure, okay, during a normal delivery. It is just collection of fluids with poorly defined margin, and it is non-fluctuating. These characteristics are very important, okay? It is poorly defined. If it is well defined, it will be like a hemorrhage or like that, okay? And it is non-fluctuating, so we can differentiate it as we will see after that. No specific treatment. Any mother will ask you what will happen for this, the skull of my baby, especially if she's briny or has a long-term infertility. She will be very worried. Why the head of my baby like that? Okay, just need to assure her, okay, that this is one of the normal things which will happen, and it will resolve within folding. It is overriding of the parietal bone. Why? Because the head circumference must be smaller as we can. After molding, the head circumference will be 10 by 10. So this is the maximum which cannot cause any laceration or tear for the mother during the delivery. So this is rahmah in Allah that the bone are able to overriding without any harm to the brain. Okay? It will disappear during the first weeks of life. Rarely, hemorrhagic caput may result in shock if it happens. Okay? Usually, hemorrhage is not common with that. So we just need to reassure. This one is the Cephalohematoma. Okay? It is a sub-periosteal correction of blood between the skull and the periosteum. What is the landmark here? You can see in that picture here. You see, it cannot cross the midline because Cephalohematoma, it means either in this parietal bone or that parietal bone or both. No issue. Can go by parietal Cephalohematoma. But for Cephalohematoma alone, it is very defined border, very, very defined border, okay? And it cannot cross the midline. Is it clear?
Yes.
Should we try to get this blood out? It is contraindicated because if you make infection in the bone, what is the name of infection of the bone? What is the name, scientific name of infection of the bone?
Osteomyelitis.
Myelitis. So someone is very active and he said, oh, let us get this blood out, and he just did for the baby osteomyelitis in the skull bone. Very dangerous. Massive one, if there is a big amount of blood, we may need to give blood, okay? Sometimes it can give us clue for some abnormality in the coagulation if it is severe or accompanied by intracerebral hemorrhage or skull fracture, okay? This is the only limitation, but usually this is a clinical diagnosis, and if the baby are stable and no issue with severe anemia or bleeding in other area, just assure the family and tell them that the baby may get jaundice. Why he can get jaundice?
Hemolysis?
Yes, the same hemolytic. crisis. Now the baby lost, let us say, 100 ml blood below the periosteum. It will be distracted into heme and globin. Globin will cause jaundice. Okay, so usually with this situation, there will be some sort of neonatal jaundice increased incidence. Here you can, anyone can comment for this nice picture? Change the rule. No one answer again. I have 25 students must answer. This is a cut in the skull. Okay, you can see here the brain. Then who will comment?
There's a caput there is multiple hemorrhage inside the caput between the periosteum and the skull, and then extradural. So basically, the hemorrhage in the caput bypass the middle
It's not hemorrhage. It is fluid just.
fluids.
Okay.
Sorry.
The tissue swelling. Okay, good. So it can cross the midline. Then what about
it is local and it doesn't cross the midline.
So it is Cephalohematoma, can be bilateral also. What is this? Is the subgaleal hematoma, which will extend until the back, which is very okay. What is this one? Dura mater. Okay. So we can go two types of bleeding. This one is extra dura. Okay. And this one is subdural one. So it is very important to know how to differentiate. We'll speak about that, inshallah, in the future. Okay? Even by the shape of the bleeding. We are not doing to do it routinely for skull X-ray unless we are suspected there is skull fracture or like that. Okay? But if you saw the X-ray, it will be looks like in front of you. Here, just a table to differentiate between the most common occurring in most of the pregnancies, which is the Caput Succedaneum, and the less common, which is the Cephalohematoma. I think you can understand the difference very easily now from the table. Caput Succedaneum will occur at birth, but this one may occur slightly later, few hours or few days. This one is diffused in the presenting part, but this is localized to the bone. This one is ill-defined edge. Here is well-defined. Soft bits on pressure. This one is elastic, doesn't fade with pressure, and it disappears within 1 or 2 days. The other one can take a slightly longer time. Okay? Everything is clear between the most common. If you asked, are you able to answer now? What is the difference between Caput and Cephalohematoma?
Inshallah, yes.
Let us see what is the hemorrhage. Some are calling it subaneuritic hemorrhage. SAH, S-A-H, is a bleeding in the potential space between the skull periosteum and the skull galeal aponeurosis. Can cause shock or pallor. How shock is appear, you must, in your life, you mustn't forget what is the definition of shock and how many types of shock and how can we differentiate with compensated or uncompensated. It's very important, okay? You will find the baby is tachycardia, but take care that the heart rate of the baby, normally acceptable heart rate is
16.
Sorry?
More than 16 breaths per minute.
The normal. This is the acceptable, not to listen.
Normal. Less
Yeah.
than 60.
Who can increase? The normal heart rate for newborn is
No, okay, I'm sorry. I'm
confused. Just a while, sorry. Hospital is calling. Alaikum salam. Tomorrow is the meeting at 11. What time can be around 2 or 3? Oh, yes, 3 or more than 3 also. Okay. Okay. Yes. Okay. Welcome. Hello.
Yes, doctor.
Can you hear me?
Yes.
Yes, doctor.
Yes, doctor.
To know what is this cancel or leave the meeting, sign in. Oh Allah. How can we do this one? Cancel. Okay, goodbye. The most important for hello, it is not working now.
Yes, doctor.
Yes. The most important for every age during your practice, you must know what is the normal, because the normal of adult is different from normal of children. Normal of adolescent is different from school, from preschool, from infant, from neonates. So the normal pulse rate of the newborn is 110 to 160. This is the normal. Also, the blood pressure of them you must know. I will not put a lot of you. Okay, so if the heart rate increased or blood pressure decreased, it means we are starting to be in trouble with severe shock. Okay, as I told you, this area can accommodate about 50% of the fetal blood. Diffuse swelling of the heart, of the head, sutures usually are not palpable at the time. The amount of the blood under the scalp is far more than estimated. Usually it is more than you feel. Within 48 hours, the blood tracks between the fiber of the occipital and the frontal muscle, causing bruising behind the ear. So you must examine behind the ear and along the posterior hairline and around the eyes. So it is considered emergency. Sometimes we need to give anticoagulant like vitamin K or FFP, or transfuse blood if it is a very big amount, and do, of course, all this guided by the coagulation profile. If it is increased, we may need to give. Some cases can be diagnosed like hemophilia like that, but it is mainly we are affected by factor 5 or factor 13. Hemophilia is not so common presentation of this. Okay. Intracranial hemorrhage, we cannot say it is due to birth trauma, but it will occur in the neonate during the time of delivery in very premature. Many studies now said there is no difference for the intracranial hemorrhage between the vaginal and the cesarean delivery, especially if the baby is very small. The very small baby, sometimes 500 grams like that, they just call us the baby already in the vagina. So to take the decision for to do or not to do, it is now opened and depend on the OMG's team, unless there is some specific things for a baby. But they said sudden compression and decompression of the head, as in breach and the precipitate labor. Yeah, can affect, especially if it is preterm or even term. This one can affect him. Market compression by the forceps also, and cause fracture of the skull. Until now, it is not related to the normal delivery. Okay, it is related to the abnormal delivery, like precipitate, like forceps. Of course, prematurity, because there is hypoprothrombemia and fragile blood vessel. All of this can bleed easily. Asphyxia due to anoxia also will affect the vessel wall, or if the baby has any blood disease, as we speak before. Many cases of factor deficiency other than hemophilia can be diagnosed upon birth. As we speak before, epidural or extradural and subdural, okay, and subarachnoid or intraventricular or intracerebral. Okay, so we have many levels. The first one is epidural, means extradural. The second one is subdural, result from damage to the superficial vein, where the vein of Galen and the inferior sagittal sinus combine to form the straight sinus. There is one case, very nice case in HTA, a vein of Galen thrombosis, and the child has cerebral palsy there. It is a very nice case, okay? To differentiate between the CT of both of them is very discriminating. We may speak about that. Subarachnoid hemorrhage, the vein of Galen also is damaged due to tear in the dura at the junction of phalanx cerebri and the tentorium, so it can cause subarachnoid, but it is not so dangerous in neonate like adults. Okay, we can accept it, a minimal subarachnoid hemorrhage, it will resolve soon, inshallah. But here, the most dangerous is the intra. Also, this epidural and extradural is not so common in neonate unless there is another pathology. Intraventricular hemorrhage, okay, into the brain ventricles, or intracerebral into the cerebral tissue. Intraventricular hemorrhage, stage 1, stage 2, usually due to birth trauma. This one is the fetus usually premature and exposed to hypoxia. This slide very important, just to give you imagination what is the hemorrhage in neonates. So we can just speak about the type: subdural, subarachnoid, intracerebral, intraventricular, and the others. Gestational age, usually this subarachnoid and the intracerebral and the intraventricular occur in preterm, but subdural will occur usually in term. Okay, it's serious. Also, this one are serious. Okay, subarachnoid is not like that. And here is the causes and the pathology. You must swallow all that knowledge. Okay, it is very, very important to able to differentiate which one is the most dangerous. For the term is the subdural, for the preterm is this 3-1. Miscellaneous can occur for anyone like trauma or hemorrhagic disease or coagulopathy, all this, or the patient needs some intervention like ECMO, which is extracorporeal membrane oxygenation. If the patient has any hemorrhage and affected, the first one is the diminished or absent Moro reflex. What is Moro reflex? Anyone knows? Moro or starter reflex?
It is a reflex response to sudden loss of support. Usually the baby will spread their arms and crying.
Yeah, this is one of the neonatal reflexes, which is a big series, which will guide us about the maturity of the nervous system. Is it mature or not? If it is lost early, it means the baby has something abnormal. And if extends after 4 months, also it may denote that the baby is abnormal. Okay, here, so diminished or absent motor reflex, or sometimes asymmetrical motor reflex also can give guide. Generally, the patient will got muscle tone is poor, he is lethargic, he got respiratory problem, and sometimes either sleepy or irritable according to the situation. Okay, so this is the clinical manifestation. You must take care about it. Also, it may be got apnea or pallor or cyanosis. He cannot suck. This is another neonatal reflex. Abnormal eye signs. Okay, the baby may be fixed and dilated. He may give symptoms of feeding intolerance like vomiting. High-pitched cry is not so common in neonate, but sometimes it happens if the baby is crying very high-pitched. You must take care. Muscular switches and convulsion is very important. Of course, metabolic acidosis and the shock decrease the hematocrit or its failure to increase. The fontanelle may be tense or bulging, and I need to comment about that, which is very important. The fontanelle of the infant or newborn and the infant are very important, significant one. Usually, it must be normotensive, but it is increased tension or bulging. You must take care about that. Of course, if we did lumbar puncture in some situation, which can be indicated and can be done, you will find the bloody CSF. So the gold standard now is the using the ultrasound, because ultrasound in your hand can diagnose usually most of the bleeding, especially the intraventricular hemorrhage. Okay, and now, and I hope inshallah all of you will start early. Whenever batch you are going for, pediatric or medicine or gynecology, you must try to know what is the ultrasound and try to prepare yourself to use it. It is a very nice machine, probe in your hand, can tell you some of the knowledge inside your patients. Okay, now there is many areas known as focus, which means point of care, ultrasound. Okay, it can give you a very knowledge early. We did it for every extreme preterm. We make it early just to diagnose if there is any hemorrhage or not. Of course, some cases, not all, may need CT or even MRI if it is severe hemorrhage and we are afraid about its sequences. Is there any treatment for intracranial hemorrhage? There is no specific treatment really until now. We just make supportive treatment and try to prevent. That's why I told you it is very important to know what can happen. If you are going to drive car, you must take care. You must know the rules. You must try to avoid the mistake of other, not yours. That is the issue. Only we can give vitamin K for the mother and give it for the baby if needed. We can make episiotomy, especially in primary and in premature or breech. We can do forceps delivery. If we carry it, it must be the most experienced, so we can bring the baby out by single trial. Okay. Here is some pictures of the intraventricular hemorrhage, which is the major cause of both mortality and morbidity. The stage 1 intraventricular hemorrhage will occur in the area known as germinal matrix. Okay, it will occur in the subepididymal germinal matrix, but may rupture into the ventricle and go to the stage 2. So if the hemorrhage is already only in the area of the germinal matrix, it will be stage 1. Okay. If it started to go to the ventricle, it will be stage 2. If the ventricle started to be dilated and like that, it will be stage 3. If we have now hemorrhage inside the cerebral cortex itself, it is grade 4, even if you cannot see dilated ventricle. Per se is stage 4. Okay. Of course, this is epidural, okay, and subdural hemorrhage. Okay, so this one is stage 1, this may be stage 2, this is stage 3, this is stage 4. Okay. So, is it clear now? Grade 1, germinal matrix. Grade 2, ventricle. Grade 3 is the dilated ventricle, and grade 4 is
into parenchyma.
good. The periventricular hemorrhage, intraventricular hemorrhage, and periventricular infarction, it is very important, okay, because the babies, when they got now infarction inside the brain, there will be area of infarction and thrombosis at the same time. After that, it will be affected the periventricular area, not periventricular leukomalacia, okay, which can be one of the signs of one of the clue for morbidities. This is the ultrasound. When you can saw, usually we are doing the ultrasound in 2 levels. One is the cranial and one is the sagittal one. In every one you can see this one, which is the cranial one. You can see both ventricle and you can define, is it normal or abnormal? Is there any bleeding here? And is it inside the ventricle or not? Is it the ventricle dilated like that? This is a very important knowledge. If the baby are very small, there is high incidence of getting intracerebral hemorrhage. So it will be around up to 70% of the baby who is delivered between 500 and 700 grams. Okay, and still, if approaching 1 to 1.5, still you can get up to 20%. Usually it will not present at birth, but about 90% of cases occur between the birth and the 3 days. That's why we must do cranial ultrasound early. Okay, 50% can occur in the first day and then after that. So it is very important to know that the preterm are more susceptible to intraventricular hemorrhage. So you must take care. How to take care? Number 1, try to decrease painful procedure for him as you can, because he will react with that. And the issue, as I told you, prothrombin is low and the vessels are also weak. He can bleed easily. So we must take care about this, please. Swinging of the blood pressure are very dangerous. So some doctors find the blood pressure is borderline, so is hurry to increase the blood pressure rapidly by inotropes. And then you find the blood pressure is high, so he will decrease it. The variation between high and low, it will bleed automatically. So try to keep the changes in the blood pressure very minimal and try to have a soft touch. Soft touch in all medicine are very important, but especially in neonate are highly recommended. Okay. This is the germinal matrix which we speak before. rupture of the vessel are very easily. After that, it will cause hypoxic ischemic changes in the blood pressure or cerebral perfusion. So any decrease in the cerebral perfusion or pneumothorax or swinging blood pressure, all this can cause the intraventricular hemorrhage. You see, this is now they are speaking about the autoregulation system of the cerebrovascular. It is very important, and also immaturity of the coagulation profile. Both of them will cause a bad effect. Cranial ultrasound, it is very important, the gold standard now. Okay. How can we prevent? So this slide will guide us to a very, very important issue in our practice. Number one, we are not only treating a physician, we must be able to be a preventive one. How can I prevent? I will just give you an example. If the patient has asthma, he can come to me 100 times in the month and I am admitting him. But if I try to prevent the disease, it is better. That is the same. If for any antenatal less than 34, there is ending and premature delivery, you must give the mother corticosteroid complete course. And better for the mother to be delivered in tertiary course where there is a specialized neonatal team. Okay, postnatal, to stabilize the blood pressure, as I told you, to prevent fluctuation in the cerebral perfusion, correction of the coagulation profile, and stabilization of the germinal matrix vasculature. Okay, some before are giving indomethacin, but it is not commonly used now because its side effects. I think steroids are very important, and the blood pressure. Subconjunctival hemorrhage, it will occur in a good percentages of the baby. Okay, it will be absorbed within a week or 10 days, and just assure the family. Even if you go through ophthalmological and they examined the retina, they may find also retinal hemorrhage, which is considered benign and will resolve alone. But the issue of documentation sometimes is needed. That is the nerve injury, brachial plexus are very important because sometimes under stress of delivery, we are trying to do traction of the neck, as in shoulder dystocia or breech presentation. Already the baby shoulder came out and the hand hanged already. So we have two types. I think you know the difference between herpes, which is C5 and C6, and the Clombex, which is 7 until T1. The herpes is the most common one and is associated with lack of shoulder motion. Involved extremity lies adducted, prone. You must be able to describe everything, even the moro. Okay. What is the name of this one? Anyone knows the name of this position of herpes?
Waiter stick.
Sorry, waiter, yes. Waiter, or sometimes said it is policeman tip position. Anyone asking for tip, he will make his hand like that. Clombex is very important. It is a rare, but it will affect the intrinsic muscle of the hands. Grasp reflex is absent, so that is very important for any cases. If even with herpes, make sure that the grasp is contacted, because sometimes it is combined both, all the cervical affection. If cervical sympathetic fibers of T1 are involved, we can find Horner syndrome. What is Horner syndrome? What is Horner syndrome? Did you forget your basic medical science? 25 candidate, no one can answer. What is Horner?
It is a syndrome characterized by ptosis, meiosis, and hydrosis that occur because of the blockade sympathetic innervation.
Very good. So you need to, please, you must keep the books of basic medical science and try to come to it back, please. It is very, very important. If you are working in medicine without the basic medical science, you may lose a lot of issues, even during education, during that. Okay, thank you. Good. Your memory is very good than others. Okay, here is the C5 until T1 and how it can affect. Okay, and which one, which nerve can be affected from that one. It is a very, very important. So what is this? Who can answer?
Oops, palsy.
Sorry?
Oops, palsy.
Why?
Because patient's left arm is it's not functioning.
Hanging.
Yeah. Also, please try to pick an important issue. You must always compare the both sides of the body. Okay, but you can see in the right side, the patient is startled and moving his hand, but the left side cannot be moved. So either he have herpes or he may have like fracture clavicle or fracture humerus. Sometimes it can do. So we need to continue our examination. Okay, usually it can be, as you said, herpes. So it is asymmetric posture. Okay. What is this? This is a typical waiter, okay, which is known as policeman or waiter position. Waiter tip position. Of course, you must join early. Most of these cases can improve with time, okay, but if prolonged, you must refer to the neurology team. This is the clumbex, okay, clumbec which appear, okay. Here you will find the sensation of the palm and the hand is diminished. It is very important, and his grasp are affected. The treatment of brachial plexus is supportive treatment and physiotherapy, and if needed, referral. Depend on whether the nerve was injured or lacerated. If the paralysis is due to just edema and hemorrhage, it will resolve with few weeks to months. If due to laceration, it may be cause permanent damage and need neurological intervention. Who can comment?
First of all, a patient have the mouth angle is shifted to the left, and then patient have lost nasolabial fold at the right side. And then the eye is not affected on the left side. So It is upper motor neuron lesion of the facial nerve.
Which side? Complete your job.
Of left side. Of right side, sorry.
Right or left? So what will happen for the eye? What happens for the right eye now? The baby cannot close.
Yeah.
Okay, so you just ask the patient if bit eldest, just try to close your eyes and try to open it. It will be open it automatically. This is a very important. Soon, I will meet you in the final bro with a good knowledge about that. Okay, go ahead. This is official policy. Okay, why? Because it is emerges from the stylomastoid foramen, and maybe some pressure or edema during the delivery can affect it. There is spontaneous recovery in the first few days. Okay, may occur with spontaneous or cesarean or forceps delivery. Spinal cord injury during delivery result in excessive traction and rotation. Okay, what will affect the spinal cord? The respiration, of course. Okay, and he will be very hypotonic, known as frog leg position. Okay. What is this oscillation symptoms? It is very important, which can occur during spinal cord injury. Symptoms is positive if break leg of the newborn with a needle, a leg will flex and extend on all joints several times. This is another oscillation other than colonus, okay, and Babinski. Skeletal muscle injury, skeletal and muscle injury, it is very important, like fracture clavicle. This is the most frequently one occur, okay? Usually it will not affect the baby badly, okay? Until he came to you after about 10 days. When you are examining, you will find a big mass calcification. Why? This big mass remember that the bone cannot heal end to end. It will not stable. The clavicle cannot do like that. So the body must do bridges around the two bones to fix it around the bridges. So it will make like a big tumor, clavicular mass, okay? And after that, the body will put the joining of the bones itself, and then he will get out that bridges. You will see him during the time of a bony mass, okay? Usually treatment consists of immobilization of the arm and the shoulder on the affected side, known as desalts bandage, should be used about 7 days if it is significant, because sometimes it is just green line. A remarkable degree of callus develop at the site within a week, and maybe first evidence of the fracture. This is the most important practical point. The prognosis is excellent. You can see here. What is this?
Left humeral fracture, green stick.
Why green stick? Is it green stick? What is the meaning of green stick?
When the periosteum is still connected.
No,
Transfer.
it is not connected. It's very clear.
Transverse fracture.
Yeah, this is complete fracture of the, you see? Oh. I cannot make it bigger. Yeah, no, green stick, it will be just squeezing and it will be hair-like, but here you cannot, you can feel that it is already completely disrupted the humerus, okay? Can occur, yes, can occur, especially if the mother has no follow-up before and she doesn't know that her baby is macrosomic or like that. But hopefully now, after most of the lady has appointment for prenatal follow-up, the results are better. But even if it happens, it doesn't mean anything. If the nerves are not affected, it will heal rapidly, okay? It is the same problem. If the patient came fully and like shoulder dystocia and there is hand inside, hand outside, and even if you open cesarean, you need a long time, which can be with the baby affected. So are trying your best, okay? Humeral fracture not common, usually green stick, but it is not green stick due to difficult delivery of the shoulder, okay? Sternomastoid muscle, okay? Sometimes there is in the breach or some maneuver of version by the ONG, it will cause tear of the muscle or fascial sheath, leading to hematoma and gradual cicatricial contraction. So it will end by the torticollis. So must be diagnosed early, okay, and treated early. So this is very famous sternomastoid tumor. Try to diagnose it early, please, and send it to physiotherapy because even it can affect the vision. Amniotic band is very dangerous one, okay? Means by amniotic band, if intrauterine, the membrane ruptured and reformed again like that. So if any part of the meconium of the amniotic band will go for any organ, it will prevent its progression. You see here the foot, it can be like that. Sometimes if it is very severe, it can cause amputation. We saw some cases of amputation of peripheries or like that from that. So it can be by proposed two causes, either localized germplasm failure, either the cell itself will fail or rupture of the amniotic fluid will cause that one. Both are proposed. Also, there is chronic, okay, chronic oligohydramnios or inappropriate size and shape of the uterus. Okay, it can cause also congenital injury. There's some deformity can occur due to decreased fluid like talibus or scoliosis or hip dislocation or limb reduction or body wall defect. All this can affect. You see this one is the congenital talibus equinovirus. It is very important. This one, finally, this one is calcaneovirus. This one is a clear form of scoliosis. What you can see here,
the head of the baby is tilted to the right side
due to
scoliosis. Oh,
torticollis. Why? We just speak about that. Due to tight sternocleidomastoid muscle. Okay, we just speak about sternocleidomastoid muscle, okay, injury. So the head and the neck tilt toward the involved side. and the shin is turned away from the involved side. Remember, the head, if it is the right side, so the head, it will be to the right side and the shin will be to the left side. Most common cause is congenital muscular torticollis due to fibrosis or vertebral anomaly like in Klippel-Feil syndrome. Okay, so don't forget, please, this torticollis. So now, which side?
Right side.
Okay, you're right.
Torticollis.
You're right. Okay. The conclusion, recognition of trauma necessitates a careful physical and neurological evaluation of the infant to establish whether additional injury exists or not. Occasionally, injury may result from resuscitation. So we need to speak about that. Symmetry of the structure and function should be assessed as well as specific such as cranial nerves examination, individual joint, range of movement. Okay, sometimes during resuscitation we must take care, because if you are going to do resuscitation and put your finger on the Zephsternum are very sharp and it can cause really injury to the liver. Okay, so take care about that, please. Is it clear now?
Yes, doctor.
Birth trauma, inshallah, whatever you come to us, you must know what will happen for the baby. You go to AMG, you must know whatever your subspecialty, it will come to you. So please don't forget this important one. Now we have another half, which is a surgical issue. Really, it is not all requested by you, okay, but we just try, I will just try to comment for you for some important points. And the lecture with your colleague, your name is, which I send the lecture, you are the group representative. Hello?
Hello, doctor.
I send you the lecture, so if your colleagues need it.
Yes, yes.
Okay.
All right.
Just let us present this one, which is a surgical issue. As we speak before, we need to go from head to toes. So we'll go through head, chest, abdomen, okay, and even neurological one. From the nose, we have choanal atresia. What is the choanal? It is the opening behind in the behind of the nose. Okay, if it is closed, just remember the baby. Is there any picture of choanal? No. Okay, just remember if the passage from the nostrils are closed by a bone or soft tissue, and remember that the baby is obligate nasal breathing. What will happen? The baby is obligate nasal breathing, so he will stay for some time trying to get his breath. He is trying to get air. Air is not coming inside. So he will stay silent, silent, silent until he became cyanosed. At the time, he will react. He will cry. When he cries, he will turn blue, pink. Just remember this. If you saw it in a video, you will not forget. Inshallah, if you make it on actual life, it is the top. So the baby already, if silent, he became cyanosed. If cried, he turned pink, and again and again. So if you didn't try to diagnose it, you will miss it. How can we diagnose? Very simple. Just OGT tube. I just speak to you before. Just pass it through the nostril. It will come back to you. It means it is obstructed, especially if it is bilateral. Okay. Of course, you must bring the appropriate side size and you must use it lubricated like that. So choanal atresia, and consider a medical emergency. Sometimes you need to intubate the baby until the AMT can do their job. Nasolacrimal duct cyst, it is large. We have already one room for tears, okay? Sometimes this one has obstruction or nasolacrimal cyst, okay? It can also affect with crying and the treatment with oral airway. What is the Beer-Robin syndrome, or they call it Beer-Robin sequence? Sequence is a different issue than the syndrome. We have now, you must know now, you are in 5th year. You must write this note and you will answer when I saw any one of you. We have syndrome, we have association, we have sequences. So says, okay? Beer-Robin sequence, it is the mandible, okay, it is small, but the issue is come from the macroglossoptosis, okay? It means the tongue already is retarded back, so he will get the mandible with him. It will cause retrognathia, and it will fall up, so it will make cleft palate, okay? So this is the 3 criteria. Hypoplastic mandible, okay, with midline cleft palate, okay. There is respiratory difficulties and feeding also. If you put him in prone position, he can be okay. And usually, if you are going to consider, you will consider nasopharyngeal tube or oral airway. Sometimes the surgery need to be fixed, okay? Laryngeal web or tracheal agenesis, it is a frequently lethal one, okay? You see, this is the vocal cord. If you are going to intubate any baby, you must see like the left, there is 2 vocal cords, okay, in front of you, this one and that one, and they are moving. Sometimes if they are paralyzed, they will be on the middle. They will not paralyze to the periphery, they will paralyze to the center. And if you have any web inside, it is very important, or behind the vocal cord, if there is any abnormality, like tracheal obstruction, okay? So this is the normal, this is the laryngeal web. Tracheoesophageal fistula. These things can occur in the chest. Diaphragmatic hernia, congenital lobar emphysema, cystic adenomatoid malformation, and the vascular ring. All this can occur in the chest of the newborn, and you must be able to diagnose. Tracheoesophageal fistula, okay, with esophageal atresia is the most common one. How can we diagnose? Also, it is very, very simple. If you pass the OGT tube through the esophagus, it will come to you back because of the obstruction in the esophagus. And you need to do X-ray while it is in place. We have 5 times of the tracheoesophageal fistula. The most common one is this one to the distal tracheoesophageal fistula, okay, with esophageal atresia. The other is a bit rare. You can see here, that is the one. You see now, if we enter the naso-orogastric tube, it will come out. Okay, if you put like under contrast, it will be obstructed here, but take care because it can cause aspiration pneumonia. How is the presentation? It is very important if the baby delivered and he is doing excessive salivation and the bubbling by his mouth as if he is eating chewing gum. It will make a lot of bubble. It is if you look at you put it in the baby, try to assess if it has just a lot of secretion normally or do you tracheoesophageal fistula. So who can comment for this X-rays, please? Who can comment for this X-rays? I need one to comment for the left side and one for the right side, please. Assalamu alaikum. Where are you? Can you hear me?
Yes, we can hear you.
Okay, so now where is the participants? I will open another one to choose. Okay, Farah Hezza.
Yes, doctor.
Go to this one. Tell me what you can see now.
So this is the X-ray of TB, chest X-ray.
No,
There
is it chest? Chest and abdomen, okay.
chest and abdomen X-ray. There is NGQ, nasogastric tube, noted up until to the stomach. The left side of the lung, there is noted cystic lesion.
Yes, there is cystic lesion. Yes, I agree.
Okay. And
so now where is the heart?
Is it bowel loop?
Where is the heart? Let her continue. Where is the heart now?
Okay, so the heart is being pushed to the right side of the chest.
Yeah. Because you can see now here is the heart and here is the liver. Okay. So what did you suspect? If you find one baby like that, the stomach are very distended and you can feel the air is continuous from here, here, from a small opening. You see, this is the opening, which part of the intestine come up, and this intestine are pushing the heart to the other side. Okay, and yeah, so tell me the full diagnosis, please. So it is left side diaphragmatic hernia accompanied by
lung collapse.
Yeah, The left lung cannot be seen at all. It may be left lung hypoplasia, okay? So that is very, very important. If you concentrate here, you will find also the child may have ET tube, he have OGT tube. This one is a temperature probe, okay? It is very. So Hassan Nasri,
Yes.
comment for the second X-ray, please.
There is, you can see the NG tube going to the, I can't see where it ends, but there is a mass on the right side of the chest,
Yes.
probably the liver or not, not sure. But on the left lung is clear, I guess. There's no signs of the stomach. Yeah, there is. I can't see the air in the stomach on the X-ray.
Okay, so good. So this is the same one. This is the most common type of congenital diaphragmatic hernia, the left side one, okay? And this is the rare one. The rare one because the liver looks like a wall, is just coming up, obstructing. There is no intestine yet coming up. Unless you start ambobagging, you will push the intestine inside, okay? And as you can see, it is already obstructing most of the right lung. It may be right lung hypoplasia, okay? So both of them are congenital diaphragmatic hernia, okay? Most common in the left side, okay? Often associated with other malformation, frequently diagnosed intra-abdominal. You must avoid bag and mask. If you know that baby has already diaphragmatic hernia, go ahead and intubate, okay? Don't wait. If he got respiratory distress. Usually, he will come with the mother with polyhydramnios. And you will find the very important scaphoid abdomen. And if you auscultate the chest, you will not hear the breath sound, you will hear the bowel sound. How much is the bowel sound per minute? Mm.
10 to 15.
No, very big number. 10 to 15 if the patient has diarrhea.
5 to 30 minutes?
No, it is only around 5 per minute. It's very, okay? So don't forget that it is accompanied congenital diaphragmatic hernia accompanied by polyhydramnios, okay? And when he delivered, you find the abdomen is scaphoid. I mean it is completely down and the chest is hyperinflated. If it delivered in the specialized centers, they will try to stabilize the baby for rapid closure of it. Otherwise, if the patient has severe pulmonary hypertension, okay, due to pulmonary hypoplasia, the baby may need ECMO for some time before. We may need to give also surfactant. They said there will be secondary consumption. It is a controversial number, okay? What is this X-ray? I think it is not so clear, okay? But you can find that the hump of the diaphragm is slightly elevated, okay? Known as eventration of the diaphragm. You can diagnose by chest X-ray, by fluoroscopy to see the movement of the diaphragm or real-time ultrasound. What is this one? If you saw the X-ray,
Pneumothorax.
Is it lung collapse?
If lung collapse, it will bring not push this lesion, push the lung to the other side. If lung collapse, it will pull. So to happen, this lesion push or pull. It goes pushing the heart.
Yes.
So
Pneumothorax.
Tension pneumothorax. Oh.
you must think about pneumothorax, but usually pneumothorax will be jet black more than that. Okay, this is a congenital anomaly. This one is a cyst. Okay, known as congenital lobar emphysema, lesions that cause trapping with compression of the surrounding tissue. So it is congenital lobar emphysema. You are correct. You must consider one of the most common is pneumothorax for this. Okay. You see, you can find it also here. This is congenital cystic CCAM, congenital cystic adenomatoid malformation. It may be also come like this, okay, and you will find this cyst inside the lung. What is this X-ray? I will choose or who is Cassandra? Cassandra? Cassandra is around today or not?
The narrowing of the esophagus.
Sorry?
Narrowing of esophagus.
I cannot understand.
Narrowing of esophagus.
Where is Zahra Nagwa?
Yes, doctor.
Is Zahra, what you can see in this X-ray, Nagwa? What is this?
Esophagus.
Yeah, this one is esophagus.
Which one?
This one. You cannot see my arrow?
The
Yes, spine.
spine.
Okay. Spine. Spine. Okay. What is this?
The rib cage.
What is this?
Esophagus.
What you can see in the esophagus?
There is a narrowing.
Before narrowing, why the esophagus looks like that? This contrast.
Barium swallow.
So this is contrast study of the esophagus. Okay, I put some dye here, contrast study, and you can see what here, what is present here, Nagwa?
Compression.
No contrast in there.
No, there is contrast, but there is indentation.
Yeah, indentation.
Pushing here. So this is a vascular ring, and it is very rare, but you are able to diagnose because as you can see here around the trachea, there is like a vascular making a ring around the esophagus and the trachea, and they can cause these effects. And sometimes associated with other anomaly like double aortic arch. Okay. So it is uncommon. Signs include stridor. So sometimes we need to do CT, we need to do with contrast, vomiting, difficulty swallowing, barium swallow can be diagnostic, but we need chest MRI. Many cases may need cardiac catheterization to rule out any cardiac problem. Okay, so this is known as vascular ring. Please don't forget the vascular issue in your mind for every patient. For the abdomen, Who will answer this question? Zaid.
Yes, I can see that the bowel is protruding out of the abdomen through the umbilicus.
So if it is through the umbilicus, it will be, what is the name of the lesion?
Gastrocolitis.
No. It is omphalocele. It is different. Okay. So this now is not coming from the umbilicus. What you can see here? What is this?
Umbilical cord.
So it is not coming from the umbilicus. It is coming from a hole left to the umbilicus, which is the most common site, known as gastroschisis. Okay? It means a congenital defect in the abdominal wall, and the viscera, usually it will come out and enter again during the intrauterine life. So when it will come out, she cannot come back. So this known as gastroschisis. Okay, you can see here, it is abdominal wall defect. Usually it is a sole. I mean, only small part who has complication like intestinal atresia like that. But what is going for this baby now? Inshallah, if someone of you became pediatric surgeon, they are thinking you must work more your mind. Upon delivery, you will sterilize everything and put a plastic and fix it down around all this viscera. So you will prevent infection, you will prevent loss of fluids, and you will hang it. And every day you are trying to push by 1 centimeter, second day by 1 centimeter. At the end of 7 or 10 days, you will find all come inside the intestine smoothly without any injury or ischemia. And if you follow up 1 cases of this, you will feel how much. Okay. Of course, I don't know if the patient has any undescended testicles or not, but you must know that most of the cases of gastroschisis usually has no more abnormalities. Okay. So now you come to the one which you speak before. Now you can find the Zahra. Zahra finished already. Okay, City is the tool. The one who got the lecture, the only one who got the lecture.
Yes, me.
Yes.
I can see the placenta is protruded out with the amniotic sac, maybe.
Okay, so this is the omphalocele, abdominal wall defect at the umbilicus with covering sac. This one usually associated with another clinical problem. It can cause respiratory distress and many abnormalities. So you see now, usually this one will rupture. That's why if this patient went to deliver in a specialized center, okay, it is better. So they will, just after rupture, they make sterilization and put cover and the same like the gastroschisis. Okay, this is just, we'll try to see you what is going here. This is the ET tube. This is the cardiac monitor. This is the intestine outside. You can see? Here the intestine is coming out. Omphalocele, you must make decompression, okay, and like that. What is the diagnosis of this one? Shah.
Yes, doctor.
What is the diagnosis?
in this case of tonsillitis, because there is an inflammation around the in the periumbilical area.
Okay, so this is very umbilical area infection. Okay, it does matter or not? Doesn't matter. This is known as omphalitis or periumbilical cellulitis. Okay, which is very dangerous. Why? We have here the main vessels: umbilical vein, umbilical artery. Still, if the staph, which is the most common, it can jump here and go to the blood and cause septicemia. So if you find any neonate with cellulitis like this, even in the nail, you must give intravenous antibiotics. Okay? So this is erythema and duration of the periumbilical area can spread to the abdominal wall and cause fasciitis and can go to the central. Usually it is staph. Here is the intestinal obstruction. No, this is the infection. Okay. And some granulation tissue can occur. Okay. Intestinal obstruction, of course, you must try to define duodenal atresia. Who can tell me what is the X-ray if some baby have duodenal atresia?
Double bubble.
Double bubble. What about duodenal? Triple bubble. Okay, it will be triple. Okay, meconium ileus, meconium plug, Hirschsprung disease, imperforate anus, malrotation, and the adhesion of the structures. It is very important. So can you see here? This is the double bubble of duodenal atresia. If in the jejunal, you will find the triple bubble. 1, 2, 3. Okay. Usually, if you find the duodenal atresia, you must rule out Down syndrome. تفضل. عليكم السلام ورحمة الله. جزاكم الله خير. Keep it there. Keep it there. I have lecture. Dr. Alawi left or still here? Yeah? Just give him his lunch. He may need to leave. And I will finish within minutes, inshallah. جزاكم الله خير. Thank you. Okay. So it is very important. Duodenal atresia, also accompanied by polyhydramnios, okay, and bilous emesis. If you found any small baby have yellow or green vomiting, take care about intestinal obstruction, okay? Meconium ileus, it can cause like this. The baby doesn't pass meconium, and when you put the dye, you will find the meconium ileus. It can occur with some cases, okay? And also meconium plug, which can occur with cystic fibrosis. But at least you must know the Hirschsprung disease. I think you will get it through your surgical course. If any baby doesn't pass stool spontaneously by 24 hours, take care. Sometimes you can give some extra few hours, okay? The diagnosis of Hirschsprung disease is by rectal biopsy. Why? To rule out a ganglionic area. So, who can diagnose this one?
Imperforate anus.
Why you said imperforate? We can see like there is something here. So usually we can find a dimple, but we can find a hole. Because we have two types of anal atresia, either low or high. Okay? So if you go for imperforate anus, the most important is not the baby pass meconium, but not through the normal. It means if it is female, she will pass it through fistula, through the vagina. If it is a male, he will pass it with urine. So don't be mistaken that the sister tell you already the baby has meconium. Oh, alhamdulillah, he has no atresia. Okay? The most important, as I told you now, we got an important lesson for using a catheter. During birth, we are preparing a catheter for suction of secretion, yes? And you must pass it through the nose to make sure that there is no nasal obstruction by choanal atresia. You must pass it through the esophagus to make sure that there is no obstructed esophagus with tracheoesophageal fistula. The last one, you must pass the catheter through the anus to make sure it is patent, even there is a dimple like this. Okay? We have two types. We have high type. We have with fistula. We need to do temporary colostomy to treat it. You can find here some illustration about that. I forgot to tell you, please take care before cutting the umbilical cord with cases of gastroschisis or omphalocele, especially because sometimes we have a small size omphalocele. If you clamp and cut it, you will make a very big incident for the baby. So every time you must. Here is they are comparing mal rotation and the volvulus, which can end by either of them can end by signs of intestinal obstruction. What is this? Abdomen is distended. Sometimes you will find changed color and erythema. Okay, sometimes you can find the vessels started to appear and the baby is vomiting or passing blood stool or like that. And he is a preterm and started on formula feeding, not EBM. So this is known as NAC, necrotizing enterocolitis. And it is very important to diagnose, is it, because it is 4 stages also. Stage 1 and 2 is just medical, but the other one are surgical. Okay. You can see these X-rays now. Speaking about the nematosis intestinalis. What is nematosis? You see now what you can see. This is the wall of the gut. Okay. If you find some dark color here, it means there is air inside the wall, known as nematosis intestinalis. This is one of the pathognomonic. So if you found the air inside the wall, or you found the air inside the liver tributaries, or find the air due to perforation and cause pneumoperitoneum, all these are a very severe NAC. Did you understand? If you find air inside the wall, or air inside the liver, or air inside the abdomen as all, it means severe necrotizing enterocolitis. Here is pneumoperitoneum. When you did the operation, you will find some necrotic if you didn't diagnose it early. What the surgeon are going to do? He need to remove all this, which can end to short bowel syndrome. That's why if you are alert and diagnosing the baby early, this is the best for the baby and the best for your reward from Allah. Dissection, anastomosis, and sometimes you need to remove this ileocecal and this big part from the small intestine, which can end to short bowel syndrome. We need one ileostomy and another one for repair. I think we have one of the cerebral palsy patient also have two scar, and most of the students cannot suggest what is this, they don't know. One for the ileostomy and one for the closure. This is a posterior urethral valve, especially in boys. They got a valve in the end of the urethra. So you will find the urinary bladder are very dilated, and also the ureter and the kidney is also enlarged. So this is an important point. If you found the baby doesn't pass urine or he has some distress or like that, make sure he doesn't, especially if he's a boy, posterior urethral valve. This one is known as Vesico, I don't know this abbreviation, with posterior urethral valve. Okay, I will revise it. You can see here what will happen. Here is the valve. So here dilatation, dilatation, dilatation for both sides. It needs please urgent referral to the urology team for possible correction, because it can destroy the kidney. Sometimes we have this exotrophy of the bladder. It means the bladder is apparent in the anterior abdominal wall. It is rare. Local also, it is polycystic kidney disease or multicystic. Sometimes we can see it. Okay, renal mass, we will speak about. You can see this one. Okay, sacrococcygeal teratoma in the sacro. This is the most common, but it can occur in many other areas. One of the tumor of infancy. Okay, here is also the sarcoma, not so common. Yes, hydrometaclopus. It means imperforate hymen. Okay, sometimes it will accumulate the blood and protrude through the genital tract. Inguinal hernia, of course, you know it. It will occur very common in premature babies. The testicular torsion are very important. Can occur intrauterine or post, and you must diagnose it early. Who can tell me what is this? Start to Hafifa. Hafifa. Hafifi, where are you?
Myelomeningocele.
Sorry?
Myelomeningocele.
Okay, myelomeningocele. Which place? Still, you can tell a lot of knowledge. It is lumbosacral, because if it is up, so you must be able to sit. Lumbosacral myelomeningocele. You may sit here with intact membrane. Here may be rupture membrane. Okay, if you found the baby is soiling himself continuously, you will sit with incontinence. So even by observation, we can get a lot of issues. Okay, thank you. Okay, this is the myelomeningocele. This is Chiari malformation. It means there is a cyst, okay, in the posterior fossa, okay. It is one of the common causes of hydrocephalus and derangement. You can go through it also. This is how we can see the ultrasound, hoping inshallah you will start early. What is the definition of hydrocephalus? Is very important because many times you are bringing a child with hydrocephalus. You must know about that, okay? And you must know the normal head circumference, okay? And compare it to the mother and the father head circumference also is very important. You must search in case, if any case of hydrocephalus, is there a shunt or not? Because many of you, the patient has shunt and they are not commenting about that. Let me, inshallah, if we start our clinical session together, I will tell you how to examine the patient in these points. I hope, inshallah, you got a good starting about these two important topics. Now it's a role to speak and ask, please, if you need to ask for any details. Is it okay? Any questions?